I call upon the next presenter, Diego, to present on the topic Seroprevalence and risk factors of hepatitis C virus infection in patients with sickle cell disease.
Good morning.
Very good morning.
I am Diego Tchouakam Nitcheu. I'm medical doctor at the Regional Hospital for of Ebolova in the South region of Cameroon. I am a general practitioner and I am presently work as a site lead in the treatment center for patients living with HIV/AIDS. The study I'm going to present to you is a study I did in 2015 on clients, on patients living with hepatitis, on patients living with sickle cell disease, and trying to find the seroprevalence of hepatitis C virus in patients living with sickle cell disease, and try to determine the common risk factors among this group of population. We use a plan. We'll first introduce our study, and then we'll later pose, we'll then do a research objective. We'll present the research objectives, the materials and methods, and then present the results, conclude, and then we'll have some references at the end. So we'll see that hepatitis C virus is a virus of the Flaviviridae family. Unlike HIV, it's a family of Flaviviridae. It's been discovered since 1989, and since then, we had in around 1989 we had about a 90% transmission due to post transfusion. So it was very high after transfusion. The prevalence has been from the prevalence of 3% worldwide in the general population, and has in the sub-Saharan Africa was around 5.8%, and in Cameroon it was around 13.8% from the literature review we did. So we also want to realize to make sure here that we have sickle cell patients. Sickle cell disease is an autosomal recessive condition with a 20% carrier trait worldwide, and 20 per 1,000 live births per year in Cameroon are born sickle cell. So this is a condition, a medical condition, where there's a mutation at the CIF codon of the chromosome 11, and this mutation will lead to a change in the amino acids to constitute the formation of hemoglobin S. The glutamine will be substituted for valine, and this will constitute the hemoglobin S. This hemoglobin S easily break down and will cause vasoconstriction with chronic anemia and recurring. These clients are recurrently transfused throughout their lives. Among the risk factors of hepatitis C virus infection, we will find out that blood transfusion was recognized as a major route of transmission before the advent of blood screening for hepatitis C prior to transfusion. And we know that in Cameroon, this was only being implemented around 2005. So many children with hepatitis C would have been infected by then. So we now know that hepatitis C is a major cause of post-transfusion hepatitis, and sickle cell disease patients are considerably transfused throughout their life. So when associating these two, we'll realize that the patients living with sickle cell disease have an increased risk of hepatitis C infection, have an increased risk in hepatitis C infection. This led us to to think about carrying out this study. We see that in clinics, in a study of post 60 of about 70 patients with sickle cell disease, was shown that 47% of them had sickle cell, 35% of them had focal necrosis, 20% had portal fibrosis, and 60% had cirrhosis due to so already sickle cell patients have a chronic hepatic condition. So a concomitant infection with hepatitis C will lead to a rapid increase into rapid deterioration of this hepatic condition, and may rapidly lead to hepatitis, liver cirrhosis, or hepatocellular carcinoma. So it is urgent for clients living with HIV or with hepatitis C or with sickle cell disease to be diagnosed early enough to be able to to reduce the trend of the evolution of the disease. So we also found out that there was a scarcity, there was a paucity of data on the prevalence of hepatitis C in sickle cell disease, and the risk factors were not well studied. So we then decided to implement this study in our setting, where we determined as research objective to determine the seroprevalence of hepatitis C virus and to identify the associated risk factors of this virus. For us to be able to carry out this study, we implemented a hospital-based cross-sectional and analytic study. And during a study period of 4 months from November 2018, November 2014 to March 2015. The study area was the Integrated Center for the Management of Sickle Cell Disease Patients, Emmanuel Belong, at the Douala Lakentini Hospital, since it was one of the major centers for management of patients with sickle cell disease in Cameroon. So we included in this study all patients, confirmed sickle cell disease patients with an electrophoresis result, and those who gave their consent. For children more than 8 years old, both consent and verbal assent was required. Consent from the parent and verbal assent from the children, since it was requiring that we prick the children to obtain blood samples. We excluded all sickle cell patients who were admitted at the intensive care unit. So we obtained ethical approval from an administrative authorization to be able to carry out this study. We took a 2-day training on research ethics and the techniques of testing, of doing the hepatitis serology testing. Participant enrollment, we then followed with participant enrollment, where we posed, it was an investigator interview questionnaire, and then questionnaire was administered and blood samples were collected. The blood were channeled to the laboratory, were coded before channeled to the laboratory, and then the tests were done and the results were then entered into a data sheet using EPM4 version 7 statistical software from CDC Atlanta, USA. We did analysis, we did a chi-square test and Fisher exact test for association between variables, and we took our statistical significance when P was less than 0.05. All participants signed informed consent form and verbal assent for children. Confidentiality, anonymity, and privacy was guaranteed, as the investigator had a well-secured notebook and a laptop which was coded, and only he had the access to the information, to client information. Now we'll present our results, what we found on the field. We approached 223 sickle cell patients were approached, amongst which 2 were excluded because they were very ill and were hospitalized at the intensive care unit. Finally, we had 221 fulfill the inclusion criteria, and 4 of them were excluded because patients who did not give consent, they did not give consent. So we finally worked with 217 sickle cell disease patients were retained with a retention rate of 97.3%. Out of these 217 participants, 54% were male and 54% were male. The majority age group represented was the age group 1 to 10 years and 11 to 20 years. We had a lesser representation of the 21 to 30 years and more than 30 years. As compared to level of education, we had most of our participants had at least primary education, and majority had done at least secondary education. We have 97% of our participants were single. If you see very well, it corroborates with the fact that most of them were very young, below 30 years. And so only a very few, about 2% were married. So we had a sample size of 217 participants were having an age, we had an age range between 1 and 47 years. And we had a prevalence of 4.6% among this of hepatitis C amongst this population of study. This was more superior to the prevalence, was less than the 13% prevalence found in the general population in Cameroon, but was also in accordance with the 7% that was found in the Kinshasa. It was also around the 3% that was found in Nigeria, in the Edo state of Nigeria, in Lomé, in Togo, in Uganda, in Turkey, and in Colombia. So all this, we had similar results with these different studies that we did in our literature review. But we had lesser, the prevalence was less than those compared with other studies, particularly studies done in Cameroon, like that of done by Ngosak et al. In 2013, who had a 16% prevalence, and Dumbe et al. Who had a 31% prevalence. But we can notice that this difference was also due to the fact that 14 to 35% of other studies, the difference in these studies was due to the fact that their sample size were far less than what we had a sample size. They are relatively 108 and 71 for their sample size. Meanwhile, we had 217. And we also noticed that their age range was greater than our age range. They had an age range of a mean age of 21.5 years. We had a mean age of 13.5. Knowing that, as we'll see in the study, we'll see that as age increases, the prevalence of hepatitis C also increases. So this could explain why they had a greater prevalence in their study. Nevertheless, this kind of raised our attention because our population was relatively young, but the prevalence of hepatitis C was really high. And so an alarm has to be placed to try to identify why this young population are having a lot of, are being at risk of hepatitis C. exactly as I was saying, the difference in age and the difference in sample size. So as we notice from here, we'll see that the prevalence increased with age. We'll see that in our study itself, when the population of 1 to 9 years had a lesser prevalence, and as you increase with age, those above 30 years, they are around 15%. So we now understand that this is in concordance with what we're saying. As age increases, the prevalence of hepatitis C also increases. As concerning the risk factors, after doing our chi-square test, our monovariate analysis, we noticed that children who were transfused, we noticed that there was a predominance of hepatitis C was greater in female than in male, with 5.6%, 5.8%. And we had those who were transfused more than 10 times had a higher risk of hepatitis C, of being infected. And those who were transfused before 2005 were also having a higher risk of hepatitis C. Sexual activity was also an increased risk of hepatitis C, and blood transfusion was an increased risk of hepatitis C. As we can see, the p-values are all less than 0.05. So we'll notice that we had age was also as we said, age was a risk factor. The older you are, the greater the chances of you being hepatitis infected. And this was in collaboration with what we found in the literature with the study done by Nerenier et al. In 2005. Blood transfusion before the advent of screening in 2005, and sexual activities were all associated risk factors that were identified during our study to hepatitis C infection. And these were all in accordance with what was found in literature, as we all have the references. We recognize that we had some limitations in our study as we use anti-HIV antibody, which is less sensitive and specific as to hepatitis C virus RNA PCR test. Nevertheless, we choose a test that we're having a 98.7% sensitivity and a 99.6% specificity. The strength of our study is the fact that so far we have the largest sample size for this study done in Cameroon. So this could be a reference. The study could be taken as a reference. So in conclusion, we had about 1 in 20 sickle cell patients who were seropositive for hepatitis C, and the most common risk factors that were seen were being age greater than 30 years, with the chances that the older you are, the more the chance of being infected, of being transfused before the 2005 era, being transfused more than 10 times, and being sexually active. Because we noticed that sickle cell patients had the tendency of being promiscuous, because they had this attitude of, I will soon die, so let me just live my life. So most of them were indulging into risky sexual activities like multiple sexual partners and all sort of orgies. They were indulging into orgies and sexual promiscuity. In conclusion, we thought of a voluntary screening, because voluntary screening is not a priority presently in Cameroon. So we thought that installing a voluntary screening should be proposed to sickle cell disease patients, especially those multi-transfused, to ensure early detection and management of hepatitis C in this population, and education of sickle cell patients on safe sexual practice should be a priority. Here are some references that we use. Thank you for your kind attention. I'm open to questions and response and comments.
Thank you so much, Diego. I request the participant to raise queries on the Q&A session or either in the chat box to Mr. Diego. We are receiving few appreciations and one more question for you. Didn't know that SCD patients were promiscuous.
Yeah, that was a surprise finding also that sickle cell patients were promiscuous. It was also a surprise finding that we had during our study. And again, we noticed that most of our participants were between the ages of 10 and between the ages of 10 and less than 30 years. So most of them are adolescent or young adults. And the fact that they have this impression that being sickle cell is paramount, is tantamount to they have a how can I put it, a shorter they believe that they have a shorter lifespan, so they prefer to enjoy whatever they need to enjoy before it's too late. So that's why they kind of indulge in promiscuous activities, sexual promiscuity.
Thank you so much. We have one more question for you. Is there any sickle cell association in Cameroon, and what measure are they taking on the sexual promiscuous?
There are two sickle cells, two repronounced sickle cell associations in Cameroon, and we shared our findings, and they embark into education of sickle cell patients to reduce this sensation of promiscuity.
Thank you so much. One more question for you. Is HCV screening part of lab tests done before blood transfusion in Cameroon?
Yes, presently the screening is done. It was installed in 2005 and it is persistent. So that's why you will notice that it's basically those who were transfused before 2005 who had an increased risk of hepatitis C infection.
Thank you so much. We have one more question. Can we associate those with HCV infection from blood transfusion to failure in our lab system? Yeah,
we can't associate it because, as I said, before 2005, blood transfusion HCV screening was not routinely done before 2005. But after 2005, the association becomes weak because blood HCV screening was systematically being done.
Thank you so much. We have one last question. Please, I want to know if you have references for the statement that SCD patients were promiscuous. Have you compared the prevalence of promiscuity in SCD patients with that of the general population to make such statement?
Thank you for that remark. That's a very pertinent remark. It's true that I didn't make any comparison between the association, the comparison with the general population, but I was maybe I use a term very without examining the term, but that was a finding that we had during our research and we didn't compare it.
Thank you so much for the wonderful presentation, Mr. Diego.